Hi, my name is Ana Ispayo. I'm going talking about antithrombotic therapy after acute coronary syndrome or PCI in atrial fibrillation. First definition. Antithrombotic therapy is the fundamental treatment to prevent thrombotic complication and death in various cardiovascular disorders. Acute coronary syndrome is the result of an obstruction of a coronary, while PCI, percutaneous coronary intervention in atrial fibrillation, is a procedure used to restore blood supply to the heart.
Well, it's been an interesting time in the last 2 years in patients who have atrial fibrillation who need to go under PCI in getting new data to help address what should be the antithrombotic mix. And following the WOOS trial, we have done studies where we dare to stop aspirin, and that looks like it's a smart answer. The concept is that using triple therapy with aspirin, a P2Y12 inhibitor, and an anticoagulant is needed for the atrial fibrillation and the stent, and yet it leads to a lot of bleeding. And so the idea is, could you take away the aspirin and have less bleeding and still get away with that from a thrombotic point of view? And the answer seems to be yes, so that WOOST and Pioneer AF and then Redual PCI all found less bleeding when you take away aspirin, and so have dual therapy with a P2Y12 inhibitor and, in the latter cases, a novel oral anticoagulant. Fortunately, the thrombotic events don't seem to be increased even when taking away aspirin. So you use aspirin obviously before PCI in the hospital, but then at discharge stop it. And we saw in Redual PCI like 30 to 50% lower risk of major bleeding and similar rates of thrombotic events. We studied dabigatran in Redual PCI, and the approved dose of 150 milligrams had just identical rates of stent thrombosis, MI, etc. So full dose anticoagulation, P2Y12 inhibitor, usually clopidogrel, although we had some ticagrelor, but then no aspirin, and the outcomes were really terrific. And so a recent North American consensus statement, I was a part of it, about 15 of us, did note that with now 3 trials showing this, that this could be sort of the default strategy, that after or at the time of discharge that you'd send people home on the dual therapy and allow risk stratification. If you had a high thrombotic risk, a left main stent or something, I think maybe a month or more of triple therapy, but to really shift towards this dual therapy as the default. And so we'll see how that plays out. There are some new trials coming, but that does seem to be a nice advantage that we can offer to patients and really reduce bleeding for them.
Application in medicine. In an international trial, patients with atrial fibrillation who had an acute coronary syndrome or had undergone PCA received a P2Y12 inhibitor, clopidogrel, and apixaban, oral vitamin K antagonist, or aspirin or matching placebo for 6 months.
Triple antithrombotic therapy is the standard of care for patients with atrial fibrillation undergoing percutaneous coronary intervention, or PCI, with stenting. Oral anticoagulation and dual antiplatelet therapy with a P2Y12 inhibitor plus aspirin are used to prevent thromboembolic events, including stroke, systemic emboli, and stent thromboses, but they are associated with a high risk of major bleeding. A potential therapeutic strategy to reduce thromboembolic events and bleeding risk is dual therapy, with the oral direct thrombin inhibitor dabigatran and a P2Y12 inhibitor without aspirin. In the multicenter randomized redual PCI trial, 2,725 patients with non-valvular atrial fibrillation who had undergone PCI with stent implantation within the previous 120 hours were randomized to receive either triple therapy with warfarin, a P2Y12 inhibitor, either clopidogrel or ticagrelor, and aspirin for 1 to 3 months, or dual therapy with dabigatran, 110 or 150 milligrams twice daily, and a P2Y12 inhibitor. The primary endpoint was time to first major or clinically relevant non-major bleeding within 14 months. The rate of major or clinically relevant non-major bleeding was 15.4% in patients receiving 110 milligram dabigatran dual therapy, as compared with 26.9% in patients receiving warfarin triple therapy. Similarly, the rate of major or clinically relevant non-major bleeding was significantly lower in patients receiving 150 milligram dabigatran dual therapy than in those receiving warfarin triple therapy. In the secondary endpoints, there was no significant difference in the rate of thromboembolic events or death between patients receiving 110 or 150 milligram dabigatran dual therapy and those receiving warfarin triple therapy. The authors conclude that in patients with atrial fibrillation after PCI, dual therapy dabigatran and a P2Y12 inhibitor significantly reduced the risk of bleeding as compared with warfarin triple therapy, with no increase in thrombotic complications. Full trial results are available at nejm.org.
Pros and cons. Pros. It has been proven that dual antithrombotic therapy reduces the incidence of recurrent ischemic events and stent thrombosis. Cons are least effective in reducing the incidence of cardioembolic stroke associated with atrial fibrillation. Uses in Ecuador. In Ecuador, the use of direct inhibitor plus a P2Y12 receptor inhibitor without aspirin is considered the most appropriate strategy for a patient with atrial fibrillation and vitamin K antagonist combined with an antiplatelet agent are above to avoid blending. And conclusion. In patients with atrial fibrillation and a recent acute coronary syndrome or PCI treated with a P2Y12 inhibitor and antithrombotic regimen that include apaxiban where aspirin results in less blending and fewer hospitalizations where are significant difference in the incidence of ischemic events than regimen that include a vitamin K antagonist, aspirin, or both.
So again, we should be clear to our audience. So with atrial fibrillation, what's the current standard of care in terms of antithrombotic therapy?
Right. I mean, typically, unless they've had first it's determining if they need aspirin or not, and then we use something called the CHADS-2 or CHADS-2 VAS score to help determine if we're going to be placing them on either vitamin K or non-vitamin K antagonist. And then now there's some data on when we put stents in these type of patients, there's some strategies with apixaban and rivaroxaban for a utilization of antiplatelet and antithrombotic. But I think as we keep saying that, and edoxaban, right, which is not much used in our clinical practice. I think all your points are absolutely correct of that. For primary care, they're not going to know the procedural angiographic characteristics. There's going to be a lot more patient-related, and that there should be comfort level in saying that, hey, we're seeing this patient, and that we don't necessarily need to have all these pieces of information, especially 3 to 5 years out, because the stent-related outcomes are dropping. You're 1,000% correct. I think in the endovascular interventional community, I'm trying to make it more aware so that this communication gap
we have to be better.
could be made quicker when we're just assessing that patient and quickly are able to at least say, hey, based on the information we have available to us today, this is the plan that we want to set in place. And,
No, I think
and I think when I'm seeing all these patients, you know, it helps me. I quickly look, oh yeah, I wanted to use it for this strategy. You know, lastly, you know, I think something that, back to your pillars, is that the non-pharmacological therapy is also important. So, for example, there's a lot of data on if a patient eats 3 servings of vegetables and fruits, there's an 18% reduction in MACE on you know, 20,000 patient population study. So simple interventions in diet and exercise as well are very important, and I think in conjunction what we're talking about can help reduce the risk.
Yeah, no, that's an important point. Lifestyle, we often don't emphasize it enough, but it can
I'll
make
just
a
say
huge
one thing.
difference.
I agree with the notes. I think one thing that you highlighted about atrial fibrillation that I just want to make sure our audience is clear about, right? If atrial fibrillation is present, and you're going to anticoagulate the patient, so first you should decide if you're going to anticoagulate the patient, and I think these days with Chad's VAS score, you know, you would say 2 or greater, most people are going to get anticoagulated.
Yeah.
The next thing you should do is say, do I need an antiplatelet?
Right.
So now we have, I think, now randomized data and other data observationally, but now randomized data that would say if they haven't had an MI recently, and when I mean recently, I mean if they haven't had an MI in the last year, certainly if they haven't had an MI in the last 2 years, there's no reason they have to be on that aspirin, and you're going to reduce their bleeding risk. So that's number one. Number two is, in your mind as a primary care physician or a cardiologist or anyone, you should have a hierarchy of what am I treating. So patient with AFib and coronary stents and MI, I'm still treating the AFib. Patient with PAD, CAD, recent MI, I'm treating atherosclerosis, and what's the time frame? Patient with no known coronary disease or maybe say atherosclerosis risk, I'm preventing, maybe there's a risk continuum. So I think one of the first steps is, again, just to remember for our pillars, but also our antiplatelet, antithrombotic therapy, what are we treating? VTE. They have a VTE event. Okay, I'm treating the VTE, I'm preventing the VTE. Now I'm done with that episode, I'm going back to preventing cardiovascular disease. So it's just important with all these
really
opportunities to think about our pyramid of therapy.
Well, it's opportunities for enhancing care or medical errors. That is,
Yeah.
the dosing of a lot of these agents, the anticoagulants, would vary, because with atrial fibrillation, we're talking.
Thank you.